an organization can't increase revenue generally unless they're adding more new patients in the mix, or if they are going to buy other practices and they want to kind of buy that reach and the book of business and the patient list and all that. So it's like buying revenue instead of creating revenue from scratch. So you want to shine some light on that? Because I don't want to put any words in your mouth. And if there's anything that you need to clarify, please do.
Yes, what is very clear is that 2/3 of all healthcare systems in the US are running a deficit.
Hey, welcome back to the show. Today we have David Sands on the podcast, Director of Healthcare at EF Hutton. David, how are you?
Beautiful. Thank you, Dave. Nice to be with you. Thank you for the invitation.
And thank you to your colleague Ray for finding us and finding the podcast and providing an introduction to get you on here. And there's a bunch of things that are going on, and we want to talk about mergers and acquisitions in healthcare. So obviously I'm on the physical therapy side. You've done a ton with hospitals and large health systems, and on the physician side and many other components of healthcare. But I want to get you on here towards the end of 2024. And then also we're going to talk about what we kind of see happening or what might happen in 2025. Talk about interest rates. We're going to talk about what you're seeing on the hospital side. And also I want to get your thoughts on cash pay versus insurance coverage and insurance, health insurance for patients, even across the country. What would be kind of like an opening, intro for yourself, just in regards to like who you are, why you're here, and then we'll kind of get into the episode.
Yes, thank you, Dave. It's great to be with you and your network. My background has always been in healthcare, mostly in biotech. I grew up in Basel, Switzerland, where I was super fortunate to have a scholarship from Novartis to develop one of the first tyrosine kinase inhibitors for pediatric cancer, with a drug that is still on the market, making $2 billion in revenues and helping a lot of patients. It was 15 years ago that I went into healthcare banking after the acquisition of the biotech company that I was working with at that point. And since then, I've been very, very dedicated to the financial services to provide banking support to biotech companies, healthcare service companies, as you indicated, but also to recommending investors the assets and the opportunities that EF Hutton were putting together on a weekly basis. We are the most active healthcare investment bank on the street today. We have the number one volume of IPOs, and we are the number one issuers of SPACs for the last 3 years. In 2024, we have seen a tremendous increase in M&A activity. We believe that M&A in 2025 will remain very positive. And according to PwC annual global CEO survey in the summer, they reported that 54% of CEOs have intended to make at least one acquisition in the next 2 years. So that means we see a lot of interest in acquisitions. With the period that we have gone through of a bear market for healthcare, we have seen a lot of companies running out of cash and having difficulties advancing their development plans. And on the other side, we have detected that on aggregate, pharma companies have an excess of $170 billion in cash, meaning there will be a lot of deal making, a lot of acquisitions beyond 2024, and we believe that this will continue in 2025.
What are some of the factors that you're seeing that affect that? You're seeing a lot more deal activity even this year. Interest rates are somewhat, they're still a little bit higher than they were in 2020, 2021, but potentially coming down later this year or into 2025. Is the interest rate less of a factor right now with that high deal activity, or is it just some of these bigger organizations, bigger companies have kind of talked to these target companies, these potential acquisitions long enough, and now these closings are just finally happening after X amount of years or time interfacing? Like, what are some of the other factors that you're seeing that would result in more deal activity this year?
Yes, we see large organizations that continue their due diligence, strategic acquisitions, and you saw Novo Nordisk acquired Catalent. We see a lot of pharma companies trying to get into the distribution of pharmaceutical drugs as an area of a strategic interest. So, in one hand, we see these strong strategic interest in big pharma. They're very diligent. They do a lot of they have a lot of decision points, and they're not opportunistic. They are very strategic, and they try to fill the gaps and create economies of strength rather than being opportunistic. On the other hand, we see a lot of companies, smaller companies, running out of cash, and we see a lot of activity that is all the opposite, that is more opportunistic, and is taking advantage of situations where there are more companies in distress, and there are more companies. If you think about 20 years ago, we had almost 8,000 biotech companies listed on the stock market. Now we have only 3,000. So there has been a big attrition of small biotech companies that don't see the benefits of being public, paying the expenses of remaining public. They have gone private, and we have seen a lot of activity in private equity taking public companies private.
Got it. All right. So let's talk about what you're seeing with health systems. We kind of talked about in the pre-interview. I mean, consolidation has happened for decades, and I suppose it's going to continue to happen with the consolidation of bigger health systems and organizations buying up the primary care physicians, pretty much any independent physician in the specialties. And then at the same time, I know some friends and colleagues, like I know a podiatrist here in Manhattan in the city, and he's independent and he wants to stay independent and he wants to grow his practice. So I'm kind of on that side of things with my physical therapy practice. I would absolutely like to remain independent, and I don't, even see the financial or the, relational benefit of being partnered with HSS or Mount Sinai or Lenox Hill or any other organization. Do you see, like, most likely, is there going to be continued consolidation in healthcare, the bigger guys buying the medium to smaller guys?
Yes, I think that there are three major drivers for why small clinics want to be acquired, and they're very obvious. The increase of rising inflation, rising of interest rates makes life more expensive, number one. Number two, we see the labor report, labor costs are increasing, okay? What we anticipate is that the next recession, if it happens, or whenever it happens, it will be mostly because of an increase on labor cost. Labor cost is one of the drivers of inflation. And when your practice has more expenses and smaller margins is when owners like to get out of that business. And last but not least, that is less intuitive, but we see happening more and more, basically the cybersecurity attacks. The cybersecurity threats have an average of $1 million per cyber attack. When some of these clinics are hit by a cyber attack, it's a big blow, it's a big attack. And we see these are the three major threats when you think of small practices, and having an exit with a major institution, it can be a good solution for some of the challenges.
So specifically about labor costs, like typically I would assume that the big hospital groups and the big systems probably have economies of scale. They probably have better negotiating power when they are paying something like even the health insurance benefits for like each employee. They probably get better rates because they have a volume of employees, regardless of if they're physicians, physical therapists, nurses, whatever it is. They have a larger volume of employees. They can get negotiated volume-based rates. So then the independent practices per employee at an independent private practice is probably paying higher dollar amount per employee for all the overhead costs, but specifically about insurance, liability, health insurance, or some of those things kind of factor into what you're saying about the employee costs regardless, but the health system would probably benefit from that with the negotiating power.
Correct. Labor cost is one of the highest costs when you think about small practices. And every time you need more data, you need more input, you need to have better service. And it reaches a point that managing a small practice, it becomes a struggle. And there is a point that it may be asphyxiating when you need to recruit more people to the same work, and there is more intensity of the work that is required. So I see a lot of practices that make the decision, the hard decision, to be acquired, because the labor cost is one of the biggest drivers of squeezing margins, and it's difficult to manage. It will not get better. It will be more expensive as we enter 2025 and 2026.
And this is where the buyers have the benefit, right? They have the benefit of the negotiating power. They can acquire the independent physical therapy practice, the private practice, physical therapy, physician, whatever it might be. The hospital now gets that kind of the book of business, if you will, the patient list, the relationships, all of that. They get to kind of absorb a little bit more of a reach in each community, wherever that practice is located. Then they get to have the immediate cost savings, like probably the next month or the next quarter or whatever. Like after the acquisition, the integration, they plug the practice into all the systems at the hub of the organization, the bigger health system, whatever it is. And then, I mean, there's always this talk of like synergies, like this synergy word is always passed around like in any M&A, but it's very obvious, like the cost savings for a bigger organization, especially in healthcare, buying some independent private practice, and then they can probably get rid of like the billing person or the small, practice HR person or whatever, because all of that, again, the hospital system already has all this. So there's typically more cost savings, right? Like when an health system or a hospital buys a private practice, they can, fire or retire or get rid of some of the redundant positions that they already have. Like they have a call center, they have a billing center, they have everything dialed in, obviously. And they get the patient list, they get the physician or the physical therapist reputation and legacy, and maybe some of the great employees and loyal team members stay. Maybe they don't. Maybe the hospital system plugs in their own team members, their own leadership, whatever, depending on the size of the practice. Those are some of the things I kind of have seen over the years. What else have you seen?
Yeah, it's very complex, because when you think about the whole spectrum of the healthcare services, it's very complicated and it's very complex. And you need to be integrated with an Epic system that can follow up with the patient, with MyChart, with the results, with the prescriptions. So for a small practices, it is overwhelming when you think that you have to compete with a system like Mount Sinai or Northwell that has economies of a scale. These healthcare systems are looking to integrate, are looking for economies of scale. They need to grow. Mount Sinai alone has a budget of $6, $7, $8 billion a year. So these are enterprises that need a lot of inflow of patients, and they need to get to the 500,000 patients a year. And it's very natural for these organizations to acquire small practices and basically bundle them up on the cost, bundling cost, providing all the services, and provides the economies of a scale are fed with these acquisitions. And at the same time, companies like Mount Sinai, Northwell, they want to divest practices that can generate a one-time payment of 100 million, 200 million. So it goes both ways. When Mount Sinai perceives that there is a business opportunity to create a one-time cash flow for a specific divestiture of a division or a practice, they will do that, seeking revenues quickly. So it goes both ways for small practices to have a payday to sell the practice to a big provider, but also for big providers, there's also the same situation. They can get advantage by selling a specific practice to a private equity fund, which is something that has been very controversial lately, because private equity funds don't necessarily run these practices the same way that the hospital used to run, with the same outcomes, striving for quality. So we have seen a lot of movement both ways, from small practices being acquired and from big organizations divesting divisions that are not as profitable, and they want to get the benefits of a payday.
Got it. Another couple of things that we talked about and discussed in the pre-interview, I was being a little negative, but I was saying, like, these hospital systems, let's be honest, this is just my opinion, but I said they buy all the specialties, they buy all the physicians up in the local city, the local town, all that. They literally will tell the physicians, don't refer to concierge pain relief, my practice for home physical therapy or outpatient physical therapy. Refer them to the, whatever the hospital-based outpatient physical therapy or whatever they're affiliated with. Like, don't refer to the private practice physical therapy or the private practice physician specialist outside the network. In my opinion, they want to kind of ping pong the same patient around all the specialties. I know you kind of pushed back in the pre-interview, so I want to give you credit. Like, you kind of said, like, maybe that's a little controversial, or there's maybe some almost like conspiracy there. But you did make a good point I want to bring up in the pre-interview, and you can shine more light on it, because you said a lot of these health systems or any healthcare organization can't increase revenue by increasing prices because of the third-party payers, right? The third-party payer insurance contracts. So whatever those contracts are, that's what they are in general. So the one thing you were saying is that an organization can't increase revenue generally unless they're adding more new patients in the mix, or if they are going to buy other practices and they want to kind of buy that reach and the book of business and the patient list and all that. So it's like buying revenue instead of creating revenue from scratch. So you want to shine some light on that? Because I don't want to put any words in your mouth. And if there's anything that you need to clarify, please do.
Yes, what is very clear is that 2/3 of all healthcare systems in the US are running a deficit. And the ones that have small margins, we're looking at 1% to 3% margins in healthcare systems. So it is a model that basically calls for a type of revenue, a type of invoice, a type of service that is fixed. You can charge a certain amount for a procedure, but you can increase cost. So it is a business model where you don't increase prices. You don't have the ability to increase prices. And the only way to create margin is to reduce cost. And that is why these organizations, for this organization, is so important that billing, outpatient outreach, coordination, everything is organized in a very efficient way, because they have to reduce costs. They are thriving to reduce costs, because that's the only way they can keep the budget for the year. And that is why many times you see large hospitals divesting some of their divisions to have a one-time inflow of cash. And many times you see the acquisitions of smaller providers that can take advantage of incorporating the economies of scale, bundling of cost, and increase these small inflows of cash. So it is a model that is very unique. It has many, as you know, many of the procedures in the healthcare system are decapitated. You have a certain budget, and you have to bundle everything into that decapitated budget. That is the labor, that is the fungibles, the medications. So it is a system where you require a lot of know-how on CPT codes, reimbursements, billing, and stretching every dollar to the maximum that you can, because at the end, your margins will be driven by how much you can control cost. You cannot increase revenues. You cannot change the price of a procedure, and you are subject to keep that in the range of the cost you can manage. And on top of this, you have to drive these systems based on outcomes. You cannot run systems on a fee-per-service model. You have to run it on an outcomes-based model, which makes the system more difficult to manage, because you have to provide a service, and the patient outcomes are you will get reimbursed based on outcomes, not based on just billing. So it makes it for very complex. Many small practices cannot support the pressure of the new model of fee per outcomes. And as long as the government keeps pushing away the fee per service, this organization keeps growing and will keep acquiring small practices that the government is making more difficult for them to survive.
Last time I checked, I think healthcare spend was like 17% of GDP. Almost 1/5 of the GDP of the entire United States is like 17 or 18 something % of GDP, which is insane. I believe this is just one man's opinion. I believe that the fee-for-service model will always be in place. I hope I'm wrong. I hope it's based on results and outcomes. I think the system is so the health insurance payment side of system, the whole system, and then the hospital organization, the way it's always been done. I don't see it ever changing. Unfortunately, I think it's here to stay. What do you think?
Yes, I mean, there are pros and cons. I'm a big believer that the self-pay has a place. If you think about New York City, it's one of the most expensive cities to be in the U.S. And there is always a pool of patients that want to pay for service. And I think about a young person. If you look at the demographics of New York, you don't see old people living in New York City. They go away after you are 70 or even younger. You leave New York because it's a very expensive place. And it is in this context that you see a growing trend of younger professionals that don't want to don't want to have a healthcare plan. They want to pay for service. The benefits is that you can see a doctor whenever you want. You pay for service, and they don't want to pay for premium, the insurance premium. And those dollars are better managed when you can basically access medicine quickly, when you can have appointments quickly. And if you think about the ecosystem of New York City, is pushing for that model. It's pushing for a model of self-pay patients. Self-pay patients have the benefit that you don't have to pay $3,000 a month. I pay $3,000 a month for my healthcare service, and it's outrageous. I don't spend $3,000 in self-pay services. So it is definitely a benefit, a self-pay system, and offices and providers that accept this type of patient. And there is a room, and there is a clear space for a benefit for a pool of patients. You have to be young, you have to be healthy. The cons is a catastrophic cost. In other words, when there is a catastrophic event, the self-pay does not protect against the major medical events. And still in the US, we have 2/3 of personal bankruptcies are because of healthcare bills. So if you have a catastrophic event, you end up in an emergency room 2, 3, 4, 5 days in the hospital, you will end up easily with a $300,000 or $500,000 bill, and that can be catastrophic for professionals, for individuals, and that is why the lack of financial protection, running your own system, your own healthcare plan yourself without insurance, that means your out-of-pocket cost will be much higher. One of the paradoxes is that if you have a healthcare plan with Cigna or United Healthcare, there's a cap on these fees. In other words, if you are a self-pay individual, out-of-pocket cost,
yeah,
it will be much higher. Mount Sinai doesn't get reimbursed from United Healthcare the same amount that if you go to Mount Sinai to get a self-paid service. So the out-of-pocket cost spending is very, very high. And healthcare systems have a negotiated price with insurance companies. So the pros and cons for me personally, I recommend people to get a healthcare plan, but I see a lot of professionals that may be a spouse with one plan. They don't want to make contributions to a healthcare plan, and they want to do a self-pay. Self-pay has great advantages. You can see a doctor immediately. You don't need referrals. You can basically shop around and the clinics that you like, that you work with, and be very satisfied, and even have prices that are affordable and are not that expensive. The problem only happens with this catastrophic event that could be devastating for a lot of individuals.
Yeah, no, I agree. Always have a health insurance plan. I believe that it's kind of like a safety net, like you're saying, for catastrophic care. And then a lot of folks in New York City, we have discretionary income. So we find whatever providers, physical therapists, physicians, whatever it might be. And a lot of them, I have patients where their cardiologist is out of pocket, the orthopedist is out of pocket. A ton of the primary care physicians in New York City that are still independent or out of network or out of pocket. I want to push back on something that you said a little bit. There, of course, I don't know what percentage. Of course, there's a lot of people that are from New York City or lived in New York City when they were a professional. And of course, they moved to New Jersey, Connecticut, especially Florida, Arizona, whatever. I agree. But at the same time, there's still a lot of older folks, a lot of geriatric folks in New York City. There's like a lot of skilled nursing facilities and retirement homes, even on the Upper East Side, kind of close to all the hospitals. So I'll push back a little bit there because like half of our clientele, we're doing home visits for geriatric age patients, and then the other half are folks like you that are busy professionals. Time's their biggest asset, and they just want someone. They want a doctor of physical therapy to come to them instead of going to an office once a week or twice a week or 3 times a week or whatever for physical therapy. But nonetheless, like that's neither here nor there. About the cash thing and out of pocket, like I agree with you. We talked about it briefly in the pre-interview. It's not for everyone. It is becoming more and more popular though. Even like the concierge, which is why it's in my name in my practice, concierge medicine, concierge physicians. You've probably seen or heard a lot of physicians over the years. They're just like, they're like, screw this. Like they want to stay independent. They don't want to deal with insurance. And then there's different models out there. I don't know what you've heard, but some of them will charge like $1,000 or $5,000 in January. And some of them charge like a monthly fee. And then it's like a reduced rate for, imaging or checkups. And then some of these physicians do home visits. I know a dentist, geriatric house call dentistry. They do dentistry in the home in Manhattan. It's usually for geriatrics, obviously. They do x-rays, they do cleanings. They can do 70 or 80% of the dental procedures in the home in Manhattan. Again, I know Manhattan is unique. This is not going to be happening in the same way in, rural Kansas. I understand. What else have you seen in terms of like private pay, self-pay, direct pay, whatever you want to call it, concierge medicine, concierge physicians? Obviously, these health systems we're talking about, they're not able to buy them. They're not able to partner with them. They want to remain independent and separate. Is that something that you've seen?
I've seen that a lot, actually. In Manhattan, you have these offices that will set up a location in a big building. The World Trade Center has like 2 or 3 of them. These are clinics that are targeting the self-pay patient to do anything. You can go there to do a consultation. You can go there to do your annual exam. They will go extensive. They will go into a more detailed analysis of your blood draw. They have their own phlebotomy clinic. They have their own kind of pathology services that they can, I'm sure that they send it to Quest or LabCorp. But definitely, I see a lot of these very smart self-pay clinics where they can set up a consultation anytime you want, walking distance from your office. And they want to basically, as you know, from your practice, medical services are very local services, okay? When you set up your office in zip code 1001, you're going to have the population of that zip code. You are targeting the population of that group. You can not set up a clinic at zip code 1001 and get patients that will come from California. So definitely is a local service. I see a lot of clinics that are growing, embedding themselves into the office space so that they can provide services to the entire building. And they will approach their employers, offer them this self-pay patient. They also take insurance, and they target to these audience of professionals that want physiotherapy, that want consultation on any medical issues, they want an annual exam, they want all these services. They want proximity. They want to be able to walk into office 8 o'clock in the morning, and by 8:30 they are gone. So this is a very smart system. I think that is taking away all the services that Mount Sinai and the big systems used to do. You used to go to the hospital to see your doctor. Now the doctor is coming to your office, as you said, is coming to your home, and they are setting up shop closer and closer to your place of work.
Yeah, absolutely. And I know some physical therapists that do that. I want to mention that in a second. Anecdotally, do you recall any? I have a hunch from what I've heard, but have you seen the one area that survived the best during COVID and arguably grew during COVID? The one area of healthcare. Do you know what I'm thinking of?
Go ahead.
Home health. During 2020, during the height of the pandemic, the fear, this uncertainty, everything that was happening, I was still out there in Manhattan and Brooklyn doing home visits with gloves on, mask on, all that. And I was asking I always ask questions, always, building relationships. And some of my patients had RNs, registered nurses, home health aides from different companies. Some were insurance based, some were private pay based. And I would ask them, like, how's it going for you? All that. And, what is your company saying about this, like in March and April of 2020? Like, is it going to be a one month thing? Like, what is your company saying? Like, how's it going? Whatever. And as 2020 went on, and then 2021 and onward, all of those RNs and home health aides and CNAs, certified nursing assistants, they all said, this is the busiest that we've ever been. My boss wants all of us to be working, is asking for us to work overtime, see new clients, see new patients, work evenings, work weekends, and they don't have enough staff. They did not have enough nurses and home health aides and CNAs to fulfill the demand at least in Manhattan and in Brooklyn, in New York City, again, a unique bubble, but this in 2020 and 2021. And the reason why I brought this up is because you mentioned, like, now the corporate wellness, the corporate health and wellness component. And one of my colleagues, Dr. Ahmed Nady, had a practice doing physical therapy, setting up like a couple of days a week in different office buildings, similar to what you said, like in World Trade Center, the Freedom Tower, and Empire State Building, and some of the other, Hudson Yards and other big places. And that whole business was annihilated in 2020. They had 10 or 11 corporate contracts that were all paused or canceled during 2020 and 2021. And the reason why I'm mentioning it is because the home health sector is so strong, and you cannot kill it. Like, if COVID didn't kill it, it's just impenetrable. Now, versus the corporate wellness, now in 2024, moving into 2025, yes, corporate model is back. You can have physicians and physical therapists like us popping up offices, speaking to the HR directors, saying, hey, we can see your employees. We take their in-network or their out-of-network insurance, whatever, building those relationships. It makes a lot of sense. But if some other COVID thing happens or some cyber attack or whatever, that's going to get decimated again, and home health will still remain strong.
Home health is very important. And you're right. After COVID, it has only increased. When we do the once or twice a week work from home, it's ideal to have your nurse to come and do whatever procedure you need to do. But I will say, even before COVID, one thing that I noticed is that healthcare systems like Mount Sinai, Northwell, they actually want to push to this home service. Think about chemotherapy. Think about end of life, okay? Hospitals don't want to manage end of life in the hospital. They don't want to do that. There's a huge liability. You are putting the nurses, the system at risk. And there are hundreds of lawyers waiting for that video or that test or that request or that autopsy. So hospitals are really pushing for this home service for their own survival, for their own interest, because they want you to stay away from the hospital setting when you expire. And this is something that is definitely it's becoming very controversial, because this is a gap that nobody wants to manage. And it's a business opportunity. I mean, let's face it. We all expire. We'll all have an end of life. Hospitals don't want to take care of you. And it's beautiful to have dentistry at home and to have physical therapy at home. But let's talk about real life. Let's talk about end of life and how we want to end our days in our home, in our bed, with our loved ones, and have the service that we need. This is something that I think could be explored. That is an opportunity there. And from my old times in the healthcare system, I always thought this is a space that, from the hospital, we're not doing a job. They don't have the capabilities. They're pushing this system away. They want you to be away. And I see very few clinics actually picking up in the most expensive part of your life. That is the last days, the last week of your life. This is the most expensive part of your life. And yet there is still reluctance to take that as a business.
Are we starting a business together? Are we starting David and David Hospice Care right now?
We're not fascinated with the end of life, because there is so much intensity. When you think about the end of life, is when the truth comes to what is important to you. I have never seen somebody at the end of life saying, David, I wish I had spent more time in the office. Or Dave, I wish I had more degrees. And the end of life is very simple. Hey, I want to be closer to the people that I care about. I want to be closer to the people that I love. And I want to have this comfort.
I want to be comfortable, yeah.
I want to be comfortable. And if you think about it, there is still that service. There is the funeral service that is very well developed, and the funeral service is a whole industry by itself. But nobody's talking about the industry of the end of life. It's almost a taboo. It's almost like this aspect of life that is still not yet approached in a strategic mindset, in a strategic way that you can think how to provide the best service and make it economically profitable.
On a serious note, or on a financial note, you're right. Like I've heard, I can't, anecdotally, I can't recall the exact number, but you're right. I heard some stat that blew me away, and it was like 80 or 90% of each individual's lifetime healthcare expenditure is spent like in the last year of their life. That's insane. Right. Think of like your whole life when you go to physical therapy, you go, physician checkups, appointments, surgeries, procedures, whatever.
You're right.
At the
Think
end
about
of
dialysis. You know how expensive it is for a hospital like Mount Sinai to run a clinic of dialysis that is, what we said before, is decapitated. They have almost zero profit. And it's like a losing proposition for a hospital to have dialysis. Think about doing dialysis at home. I mean, every time we need to take a patient from home to the hospital to the dialysis, it's already $150 for transportation. It's already having the staff, having the real estate. Why are we not doing this at home? Why don't we doing the simple things at home with a nurse that can make her a business, with a provider, with equipment, with the monitoring, and the doctor can be in the hospital monitoring the results. And we know it's the end of life. I mean, when we're in dialysis, we don't live more than 5 years. So why don't we bring this to the next level? Bring it to more quality, more care, more benefits, more support, because it is very expensive for the hospitals to run this service, and it doesn't do any favor to anybody.
So expensive for dialysis because of the cost of the treatment, specifically?
It's expensive.
The cost of the equipment,
$100,000 a year.
And the overhead of the facility?
Yes. And the margins are very tiny for hospitals to run this service, very tiny. And it costs $90,000 every year we have a patient in dialysis, $90,000. Imagine that we can have machines, we are already in the market, that are portable, that can come to your office, can come to your home, plug you there for 2 or 3 hours, and come as you need, because you need dialysis service every 2 or 3 days, okay? So imagine that we can do this more frequently. You can have a zip code. Again, this is local service. When we talk about healthcare services, it's local. It's not something that you can do for 20 zip codes. You can employ so many people. It's like Uber. It's like Airbnb. These are local businesses that you provide, you democratize the access to healthcare. And that is where I think that business and funding and investment should go, in home services, end of life, chronic diseases that are very expensive. And if you do it well and you scale it well, you can have tremendous benefits. I want to see the Uber of nephrology. I want to see the Uber of chemotherapy. I want to see these guys being able to somebody provide them all the tools and democratize the access to medicine. And nurses are the chief officers of these type of enterprises. And we need to empower nurses more than ever. I don't want to say anything bad about doctors, because obviously we need them, but we need to empower these nurses. You saw what happened with COVID. We were paying $350,000 a year for nurses to travel to New York to provide services. We need more people in nursing. We need to democratize the access to medicine, and we need to Uberize the service of nursing.
Fascinating interview. If there are any nurses ever watching this, reach out to me. Maybe there's some partnership we could do, or some business idea potentially. You have to be an entrepreneurial nurse for sure, with an entrepreneurial mind. David Sands, Director of Healthcare at EF Hutton. David, thank you so much. And let the audience know whether it's your website, LinkedIn, email address, whatever, a good place for the audience.
They can reach me on LinkedIn. I will be happy to entertain the next webcast. And I look forward to seeing you again.
Excellent. Thank you, David.
Thank you, guys.
Hey, it's Dave Kittle. Are you a healthcare business owner or physical therapy practice owner who is looking to figure out your succession plan or exit strategy? We might be able to help. And in fact, we may be interested in acquiring your practice. If you're interested, you can reach out to me. Shoot me an email at Dave at conciergepainrelief.com. That's DAVE at CONCIERGE painrelief.com, or you can call me at any time, 646-781-8884.